record this. So welcome to our PCORI-sponsored webinar series focusing on metastatic cancer patient outcomes. I'm Jill Peltzer. I am one of the co-leads for this project, and Dr. Dan Welch is also a co-lead, and he's with us as well today. We're going to focus today on access disparities in cancer and how that impacts the ability for individuals with cancer to participate in clinical trials. The webinar objectives today are to describe disparities in access to care between rural and urban communities, explain financial toxicity and its impact on patient quality of life and outcomes, examine strategies to increase access to clinical care and research, and discuss the impact of disparities in care, access, financial, etc., on research for patients with metastatic cancer. We have a panel of 3 experts who will each present, and then we'll open up for questions and discussion. So please use the chat box to type in your questions or comments during the presentations. We will make sure that we leave ample time at the end to go through them. So today, our panel presenters are Dr. Joe Unger, Ms. Lisa Smith, and Dr. Gary Doolittle. Dr. Joe Unger is an assistant member of the Cancer Prevention Program at Fred Hutch Cancer Center and an affiliate assistant professor at the University of Washington School of Public Health. His research focuses on the interface of cancer clinical trials and population health, particularly exploring barriers to clinical trials. Dr. Unger is also a health services researcher and biostatistician at the SWOG Cancer Research Network Statistics and Data Management Center. Ms. Lisa Smith is a PhD candidate at the University of Louisville Kent School of Social Work and teaches in the graduate program at this institution. For the past 5 years, she has worked under the direction of Dr. Karen Kaiser, professor and endowed chair of oncology social work. For her dissertation, Lisa has been investigating the role of social support on financial toxicity due to the cost of cancer care. Lastly, Dr. Gary Doolittle is the Capital Federal Masonic professor and director of the Melanoma Sarcoma Program at the University of Kansas School of Medicine and the medical director for the Midwest Cancer Alliance. His research centers on oncology health service delivery through telehealth. Dr. Doolittle also serves as the medical director for the Center for Telemedicine and Telehealth. So without further ado, please welcome Dr. Unger.
Hi, Jill. Can you hear me?
Yeah.
Thank you. Hello, everybody. Just to reintroduce myself here briefly, I'm Joe Unger, and I'm a member in the Public Health Sciences Division at the Fred Hutchinson Cancer Research Center, and I'm also a health services researcher and biostatistician with the SWOG Statistics and Data Management Center. SWOG is a large national clinical trials network group sponsored by the NCI. Today I'm going to discuss a recent study examining survival outcomes for rural versus urban cancer patients treated in clinical trials. Next slide, please. Just to start with some brief background. Rural patients with cancer have worse outcomes than their urban counterparts, as we all know. A recent report from 2017 indicated that age-adjusted deaths for cancer per 100,000 persons was 180.4 in rural areas versus 157.8 in urban areas. Recently as well, the Cancer Moonshot Initiative indicated the importance of increased research into disparities between rural and urban patients. Next slide, please. And indeed, some research suggests that disparities in cancer outcomes for rural patients may actually be increasing rather than decreasing. Prior studies about rural-urban disparities in cancer patients have relied on cancer population data and so did not well control for differences in access to care. So researchers have ended up questioning whether observed differences in the general cancer population were due to intrinsic clinical, demographic, or disease factors or differences in access to quality care. Next slide. In contrast, clinical trial patients receive protocol-directed care by design and by the fact that they're in a clinical trial. These patients are uniformly staged, treated, and followed under protocol-specific guidelines, and this largely reduces the influences of inconsistent pretreatment evaluation, care, and post-treatment surveillance. Therefore, large clinical trial databases are ideal for examining the impact of rural versus urban residency on cancer outcomes while implicitly adjusting for access to care. Next slide. So our research question was, do rural and urban patients with cancer receiving similar care in clinical trials have similar outcomes? Next slide. We examined patient enrollments from SWOG phase 3 trials from 1986 to 2012, and we combined data from trials of similar histology and stage to increase power, constructing 17 total disease-specific cohorts for analysis. We used 2003 rural-urban continuum codes matched to patient zip codes to identify residency status using a commonly used split point of 3 to distinguish between rural and urban patients. Next slide. Each analysis adjusted for important demographic variables, including age, race, and sex, and disease-specific clinical prognostic variables. We examined multiple survival outcomes, including overall progression-free and cancer-specific survival, and we focused on the first 5 years of survival to emphasize outcomes proximally related to disease and treatment. Next slide. We generated Kaplan-Meier overall survival curves for each cohort by rural and urban status and conducted multivariable Cox regression to estimate the association of residency and outcome, controlling for demographic and clinical variables, stratifying by study. Next slide. So in total, sorry, previous slide. Thank you. No. The map, there it is, thank you. In total, we examined nearly 37,000 patients enrolled from 1986 to 2012 from all 50 states, from 44 different trials, again constructing those 17 separate disease-specific cohorts. The distribution of the enrollments are shown in this map, with the red dots indicating enrollments from rural areas and black dots indicating enrollments from urban areas. Overall, 19.4% of patients were from rural areas, which is similar to the US cancer population. And on average, we oversampled regions from the Midwest and undersampled from the South, but within those regions, the distribution of rural patients was very well balanced. Next slide. In general, rural patients were more likely to be 65 or older and less likely to be Black. Moreover, importantly, clinical prognostic factors were similar between rural and urban patients. Next slide. So this somewhat busy figure summarizes the examination of the different survival endpoints, including overall survival, progression-free survival, and cancer-specific survival for each of the 17 disease cohorts we examined. Therefore, this numbered 51 different regression analyses, which is the important point because in only 2 instances, highlighted in the red, did we find evidence of a statistically significant difference with patients from adjuvant breast cancer trials having worse overall survival and marginally worse cancer-specific survival. But there were no differences between rural and urban patients in any other examination. So the details of this slide aside, you can see that there were a lot of examinations and very few instances, almost none, of differences in survival outcomes between rural and urban patients. Next slide. We had 2 primary questions of concern from our base case analysis. First, we wondered if the results might be due to the definition of rurality that we used, using a cut point of 3 to define rural versus urban areas. And we wondered as well whether the findings might be due in part to truncating survival at 5 years for this wide mix of cancer types and prognoses. Next slide. So in a sensitivity analysis, we examined all definitions of virality using all 8 possible RUCC cut points and systematically investigated the different amounts of follow-up by allowing follow-up to vary from 1 to 10 years. So for 17 cancer types with 8 possible definitions of virality, each examined with 10 different follow-up times, we generated 1,360 analyses overall. Next slide. The results of these sensitivity analyses are shown in this somewhat indecipherable figure where we plotted the statistical test scores from tests of global trends across the 18 disease cohorts for each combination of RUCC and follow-up cut points. And you'll notice that none of the plotted points falls outside any of the horizontal lines, where the horizontal lines indicate different critical levels of alpha. This means that we found consistent results for any combination of rural and urban definition and follow-up time, which indicates in the end that the results were robust under different critical analysis design assumptions. Next slide. So in summary, rural trial participants were older on average and less likely to identify as Black than their urban counterparts. However, after adjustment for these factors and important clinical prognostic factors, we found no systematic pattern of differences in survival outcomes by residency status, which stands in contrast to much of the previous literature. These results were similar regardless of variations in the definition of residency and the amount of follow-up examined. Next slide. Since 1 in 5 cancer patients live in rural areas, these findings have potential policy implications for this large population of cancer patients, since they show that rural and urban patients with cancer receiving similar care also have similar outcomes. Therefore, a reasonable conclusion would be that the best means by which to improve outcomes for rural patients with cancer may be simply to improve their access to quality care. I say simply, it's a simple conclusion, but not as simple to implement. Next slide. As many of us recognize, it is more difficult to access adequate medical care for rural individuals. Recent oncology rural oncology resources are sparse, with only 3% of oncologists working in rural areas, as indicated in a recent ASCO study. Further, rural patients have to travel farther and are least likely to have private medical insurance. So rural patients have also benefited disproportionately from the recent Medicaid expansion. Next slide. Given this context, potential measures to improve outcomes for rural cancer patients would include better access to affordable health care insurance, better access to treating specialists, improved resources for traveling to receive care, and possibly as well, innovative new networks to give rural patients access to new novel treatments and clinical trials. Next slide. So I just want to acknowledge here in conclusion my co-authors shown here in the red highlight, especially Dr. Don Hirschman at Columbia and Dr. Banu Symington at Sweetwater Cancer Center in Idaho. And would like to conclude, next slide please, by quickly mentioning that Dr. Collins, the NIH director, tweeted about this study, which I think indicates the importance that the NIH and the NCI with which they regard the topic of rural-urban healthcare disparities. Thank you. And with that, I would like to turn it over to Lisa Smith.
Great. Thank you so much, Dr. Unger. And now, Lisa.
Having me here today, I'm really grateful for this opportunity to talk to you all about financial toxicity and how it impacts patients. Next slide. So cancer diagnosis and treatment costs can be economically devastating for patients. It causes an accumulation of enormous amounts of debt and related stress. It can negatively impact the economic stability of not only the patient, but their families as well. For the past decade or so, financial toxicity has been this term that's been used to describe this financial burden and the distress experienced by patients in both an objective and a subjective way. Next. So objectively, patients are faced with expenditures of direct and indirect medical costs. So direct costs include medical bills, premiums, co-payments. Indirect costs include over-the-counter medications, travel expenditures to and from treatment, prosthetics, childcare. These additional and often unexpected expenditures can tax a person's budget. And to complicate matters further, cancer care often takes time away from working hours. Some patients may not be able to work during their cancer treatment phase. They may only be able to work part-time hours. They exhaust their pay.
Lisa, this is Dan Welch. I'm sorry to interrupt you, but several of the people in the chat room are saying they're having a difficult time hearing you. Can you move closer to your microphone?
Sure, and I'll try to talk up louder.
Thank you.
Yes. So not only are patients experiencing a difficulty as far as working hours, caregivers may also need to take time away from work to provide support and care. In a 2015 study, they found that cancer patients in the United States lose up to 5 weeks of working hours during their cancer treatment. And it can take up to 5 years or longer for patients to financially rebound after their treatments. Due to the offset in income and expenditures, patients are faced with potentially losing possessions such as their homes, their automobiles. They may file for bankruptcy. A few patients from our study found themselves to be homeless for a period of time, and others received constant collection calls, just compounding the stress that's associated with their cancer experience. In our study, we also had a patient who had commented on the overwhelming number of bills that come through the mail, bills and insurance forms, and just constantly being bombarded by the costs of their care. And this one patient had joked with us that she had a filing system that included a trash can in her kitchen and one in the living room. And the subject is not a joking matter, but it just leads to that subjective experience that is brought on by the cancer costs. And that's the next slide. So subjectively, patients are just overwhelmed by their experience, their medical costs, sheer number of bills, and they experience anxiety, depression, a fear of having to choose between whether or not they receive their cancer treatments or they pay for their daily living expenditures. Patients in our study had expressed a fear of not being able to cover their medical expenses and then being rejected that care. So other patients had experienced feelings of embarrassment and guilt associated with being in this financial predicament. And that can lead to the patient being isolated because they're not willing to talk to others about what they're going through and this financial burden. Ultimately, the septic situation negatively impacts not only the patient's financial well-being, but their overall quality of life. Next slide. So patients have reported to do a number of different things to alleviate financial stress. They pull from their savings accounts, their retirement funds, they sell possessions, they borrow money, they rack up credit card debt. They cut back on discretionary spending. They trim corners where they can on food, clothing, and entertainment. Next slide. Most troubling, though, is that many patients do not adhere to medical treatment and recommendations. In a 2014 study, the United States had the highest level of medication non-adherence compared to other industrialized nations. Participants in our study replicated what has been found in the research, and they reported to miss scheduled appointments, self-select to not receive treatment or surgeries because of the costs. Patients chose to not fill or only partially fill prescription medications. They put off obtaining other forms of preventative care like eye care, dental, other screenings that they felt were non-essential care. Caregivers may also neglect their preventative care. In a 2018 annual healthcare poll just last year, found that 3 out of 10 Americans delayed medical treatment in the past 10 years due to costs. Next slide. So predicting those who are at risk of financial toxicity is a challenge, and even those with insurance can't often pay their medical bills. Some studies have found that individuals who are younger, ethnic minority, have less than college education, unemployed, underinsured or uninsured, have a lower income bracket, are more at risk of financial toxicity. Research also shows that they're more at risk for worse health outcomes, possibly due to delaying care. Now in our study, financial toxicity does not appear to be selective. We've had participants with all types of backgrounds, all types of career positions, educational backgrounds, marital status, from a high to moderate, low income brackets, all having the perception of experiencing a financially toxic situation. I also suspect that extended cancer care needs and other chronic illnesses may be found to have an impact in this equation as well. Next slide. Now I've really painted a bleak picture of what cancer patients can experience, and up to this point, there's not a lot of research out there on how to fix the problem, or at least not solutions that are easily obtainable. So what I'd like to present for you now are some suggestions that we received from patients who participated in our studies on how you can improve the situation for yourself as a patient and then from the medical perspective. So for patients, it's really important that you talk to other people about your financial concerns, asking for help and guidance from family members and friends, from your medical professionals, your cancer centers. Some insurance companies even offer financial navigation services as well. But letting others know that you need help and that you're struggling with this will help you to get potentially resources and direction to such. Asking questions is another important thing. If you don't understand why you're being billed for something, if you don't understand why your insurance claim has been denied, then asking questions, it may be a simple billing error. If you don't have the energy to do this because you're going through cancer treatment, finding somebody to advocate for you through this process, a family member, a friend, someone you trust, someone who can be your voice through this process, because this is a we disease. It's not just a you disease. And talking to others about your concerns is a way that you can rally some social support. And then in the studies, several participants over and over made the comment, don't stress about your finances. And I know that's easier said than done, but that was their advice. Next slide. From a medical provider perspective, engage in those critical conversations, asking patients directly, do you want this information on costs? Ask them directly, how is their financial well-being? Are they experiencing stress associated with the cost of their care? Not every patient wants this information, and that's okay, but several studies have indicated that patients want to have this discussion with their medical providers. We explored this question in my dissertation and found that over half the participants wanted the information, wanted to engage in that conversation, not necessarily with their doctors, but with somebody, a financial advisor at the hospital or a social worker. And some of them did indicate yes with their physicians. But many of those participants also noted that they would not use that information to base their medical decisions on, but having that full disclosure and knowing what to expect can help them prepare and know what's coming down the line. From a larger medical perspective, systems-wide, simplifying the process, offering a centralized resource center where participants, patients can go and get information on financial resources and financial guidance would be helpful. A lot of places do offer a resource center, but a lot of our participants had noted that they didn't find the information that they needed. So being sure that we're providing patients with the information they need when they need that information. Also simplifying billing information forms, medical forms, insurance forms, making them patient friendly. Another like dream change would be to have some sort of centralized billing system where they get one bill and it also tells them where their insurance process is at, where claims have been made or denied, and instead of having to get multiple forms throughout the mail, on a daily basis, just being able to go to one place, a one-stop shop to get all that information would simplify their process. Offering guidance and services, financial navigation, having somebody to walk patients through their medical bills, walk them through insurance so that they understand their insurance. The appeal process can be very arduous. Also having somebody to help them through the applying for government assistance like disability and Medicaid. Those systems can also be very arduous and difficult for patients to navigate. So all in all, I think in order to truly enact change and improve conditions for patients, a really large systemic change is needed. Healthcare is was one of our top issues in the 2018 election, and I believe it's going to continue to remain a top concern and issue for everyone as we continue to face increasing costs in care and related financial toxicity. So with that, thank you so much for having me here today.
Great. Thank you, Lisa. And we will turn this over now to Dr. Doolittle. So I'm going to stop sharing and you'll be able to share your screen. Okay, great.
There we go. Well, good morning. Jill, are we projecting okay?
We can see, I think if you go to display settings.
Yeah, here we go.
There, yes.
Better?
Yeah, that's perfect.
Great. Thank you. Thank you. Thanks for the invitation to speak this morning. This is kind of a topic I've been very interested in way back from when I was a new faculty member at KU. I did my training at the University of Kansas and intended to go into private practice as a medical oncologist. And while I was training, within a year's time, I lost both my parents and my oldest brother to lung cancer. And one of the things that really impressed me through that period was how difficult it is to access the medical system. And I'm a medical oncologist, and my family members had cancer, and we were living in an urban area, and it was amazing to me, the challenge of just getting everybody up out the door in clinic, get treatment, and get home. And with that, I came on as a faculty member, and one of the challenges that we have as a university, or one of our missions, frankly, is to enhance and provide care, either directly or supportive care, to people that live in the state of Kansas. So it was a natural for me to try to look at ways to improve the care of the rural cancer patient and improve their experience, recognizing when you have all the resources at your fingertips, it's still a huge challenge. And if you reside in a rural area, it's just compounded by issues of travel and financial constraints. So I didn't go to medical school with the idea that I would be practicing as a telemedicine doc, or the jargon we use is tele-oncology. That wasn't even my radar screen. But that's kind of what evolved in the first 5 years as in my practice and as a member of the faculty in the Division of Oncology. I just wanted to give a brief overview. We're going to talk about the Cancer Center mission, and then an overview just about telemedicine and tele-oncology and how we can harness the technology to provide state-of-the-art access to cancer patients that are in the rural sector. We can talk about some of the applications of telemedicine, again, to support the care of the cancer patient. I'd like to go over a model of clinical trials access using the technology, and then maybe review just some of the challenges that we have when we're trying to use the technology in this way. So I am a faculty member at an NCI designated cancer center. I'm spoiled in that I have so many different members of the faculty that can help in the care of the cancer patient. We have state-of-the-art technology. Our director for the cancer program here, Dr. Roy Jensen, actually feels like a big part of our mission is to enhance the care of people in our catchment area, which would be the state of Kansas and the western part of Missouri. One of the things, even if we're not providing direct cancer care, it's supporting community oncologists and practitioners that are sprinkled throughout our state. It's a big challenge, I think, to practice in the rural sector, and anything we can do to support that practitioner, whether we're talking about advanced practice practitioner or physician, is wildly beneficial to the patients in that community. So part of our goal, of course, is expert cancer care, and to deliver that within our own clinic structure, but also within an outreach clinic structure. To develop innovative clinical trials and offer innovative clinical trials to people in the state of Kansas. It can be a very isolating experience in the state to practice and care for a cancer patient if you're one of 2 physicians in the county. And so, continuing education opportunities and spreading the word about new diagnostics, new therapies, new prevention strategies is part of what our mission is. And then supportive care services, and these can be directly for the cancer patient, cancer survivors, co-survivors. It can include patient navigation. It can include mental health services and psycho-oncology type care. The problem is we live in a large state. Our population is about 2.9 million. If you drive from the eastern part of the state to the western part of the state, you're really looking at a 7 to 8 hour drive. The medical center where we practice, or where I practice, is in the far eastern side of the state. And yet we have this mission to support care throughout. And if you look at the population demographics, 75% of the population of Kansas lives in one of 3 cities, either Kansas City, Wichita, or Topeka, that were surrounding counties. And this slide just gives you an idea of the population demographics. The very light colored, I don't know how it's projecting for you, but it's actually a light purple. Those counties are very sparsely populated. They're considered frontier counties with populations of about 6 persons per square mile. And suffice it to say, I work in a very rural state, and part of my mission is to see that if you live in the far western part of the state in a town of 800, you have access to the same type of cancer care and quality care that we can provide in the urban sector. I had to put this in. It's actually the first telemedicine unit that we have. We purchased at the University of Kansas. This is from 1994. It's actually a connection between the University of Kansas on the eastern part of the state and a community called Hays, Kansas, which is about a 4.5-hour drive west of Kansas City. The two people in the monitor actually are two nurses that were staffing an oncology clinic in that community at the time. We paid $125,000 for this unit, and it was considered to be a mobile unit because it sits on wheels. Never mind the fact that it took 6 men to move this from one room to another. It was the earliest form of mobile telemedicine technology that we had at KU. And with that, with the purchase of that, we decided to try to harness the technology for patient care. And the first practice that we started, in which the medical oncologist was at KU and the patient was in the rural sector, was actually a connection between KU and Hays Medical Center. It was, in a sense, it was a combination practice in that we used the telemedicine technology to see and evaluate patients. So we had clinic times that were set twice weekly for that. And then we had outreach clinics that were set up at least monthly, in which medical oncologists would actually fly out to Hays, see patients in person, and then fly back. So it required a lot of coordination between the two sites. I served as one of the medical oncologists at KU, and I was practicing with a group, frankly, that was 285 miles away from me, and yet we tried to adapt the practice to what we would have done if we were in the same room together. Took a lot of administrative support, took a lot of tech support at the beginning, but honestly, as you all know, at this point, things have really changed radically, and this is even considered a bit of a dinosaur, to tell you the truth. It's a desktop unit that is a little bit bigger, a little bit more cumbersome than some. But this unit, new, and it's now 8 years old, new was $5,000, and now you can buy something like this for about $1,800. And you don't even need to do that, because the handheld technology, iPad technology, and others can still connect the practitioner with the patient from a distant site. So things have, technology has remarkably changed in the last 25 years. That's just a given. Having said that, I think it's important to point out that we use the technology to manage a broad section of cancer patients, and they could have solid tumors, they could have blood-related tumors, but also blood disorders. So much of what goes into the assessment of a patient comes from the history alone. Taking a good history and having the video connection with the patient, we actually felt like our care was state-of-the-art, and actually generated data to show that we were our evaluations that were being done electronically were similar to, but not identical, as the evaluations of the patient in person. Ridiculously cost prohibitive early on, using technology to care for cancer patients in the rural sector. Our first visits were about $800 a pop, but very quickly over time, within 10 years, it dropped to about $250 per session. And if you look at it now, in our cancer center, our bricks and mortar cancer center, every time somebody walks in the door, it's $312. Just having the infrastructure in place to support the care of a cancer patient is extremely expensive. Bottom line, the cost is no longer prohibitive. If anything, depending upon the infrastructure that's in place, it's less. It costs less to provide care in a manner like this. And the other issue is the acceptance piece of this. Starting in 1995, and these huge rooms and huge units and everything, now we're in just a completely different world, right? We're in an iPhone, iPad world. Sometimes I'm jealous of the trainees that I work with, the students and the house staff. They have the world's literature on their iPhone, and I remember a time when it was much more cumbersome to stay up in the literature and to keep track of everything. So when we have grandparents that are FaceTiming their kids from halfway across the country, we have ICU doctors that are having Zoom meetings with children that are in Afghanistan, connecting with their parents in the intensive care unit at KU. So, we're so far beyond the issues with technology and really are at a point where, adapting the technology or using the technology to provide care is much more acceptable and much more cost efficient. So how have we used it? We've used it for direct patient care. So the managing oncologist would be in Kansas City and then has oversight for the cancer care of the patient at a distance site. The other thing we've done is we offer second opinions over the system like this. Again, this is really an older unit. This would have been right around 2000, in which we've got a cancer patient that's a 2-hour drive from Kansas City that's getting a second opinion without having to make that drive down. It also enables us, the technology enables us to have multidisciplinary conferences, which is really a state-of-the-art feature of the care of the cancer patient. Even from the time I trained in the early 90s, multidisciplinary care was the standard, and that can be very difficult to access if you're in the rural sector, but harnessing the technology and bringing multiple experts around the camera to weigh in on the care of the patients is a great use of the technology, saves tremendous amount of time and money, and then the burden of travel. What about clinical trials? That, again, in the cancer world, clinical trials are standard of care. It's not this big edgy thing that we offer as medical, surgical, and radiation oncologists. This is the standard, particularly for a patient that has an incurable malignancy. So part of what we had developed was a clinical trials network in which we use the technology to underpin some of the work that goes on. And sorry, we're backed up there. And at this point, we have multiple members of the clinical trials network that are spread throughout the state of Kansas. Now, these sites are staffed with medical oncologists, oncology-trained nurses, pharmacists. They have the infrastructure to provide care locally. And the slide that I have here, it shows all the members of our organization, but among these members, 8 of them have the infrastructure in place locally to offer clinical trials. Again, it's just so important that patients across the country, I guess, patients across our state have access to clinical trials. I mean, we just heard from Dr. Unger that patients that go on a clinical trial in the rural sector have the same outcome as those in an urban setting. So, setting up this kind of network through the state, I think it again is a service that should be offered for any cancer patient. But what about using the technology for this? It's something I've really been interested in, and we've looked at this and thought about this really since the late 1990s, using the technology in which the patient is at a rural site and receives care at the rural site, but the practitioner is actually in an urban center. We thought initially in setting this up that it would be a relatively easy process because we'd worked with telemedicine and worked in tele-oncology for literally years before we tried to launch a project like this. But frankly, in doing so, our pharmaceutical partners were very concerned about trying to spread this out through the state. And for those of you that work in the clinical trials arena, that's really no surprise. And I have to admit, I might have been a bit naive early on, thinking that we would be able to adapt this with ease. Part of the challenge, of course, is you worry about the quality of data. You want to make sure that the patient gets the same type of care on study in the rural sector as they do in the urban center. You want to make sure that your nurses, pharmacists, all the people that are involved in the care of the cancer patient are trained not only in the care, but in data management with respect to the research trial. And making sure, again, that the quality of the data is the same as it would be if you access the trial from an urban center. And the other piece that's very real from a pharmaceutical perspective is the monitoring, because if we have 8 sites in Kansas that offer a clinical trial, then that pharmaceutical company wants to send a monitor to all 8 sites to take a look at the to monitor and to look at the data. So bottom line, it was a big challenging process to work with and to try to launch studies like this. We did find a partner in Novartis. And in that, to be frank with you, it took us 2 years to negotiate and work through the process of a clinical trial and getting it launched. And Novartis was working through their system. I was working through the university system. And it took 2 years to actually negotiate how something like this would unfold. That was a little challenging, but having said that, once you go through it once, the subsequent trials that we were looking at, the time frame was much shorter. So it was an investment up front, but in the end, being able to offer a state-of-the-art trial to a patient in the rural sector is, I find the work really gratifying, and I think it's really important for the care of the cancer patient. And again, would mention Dr. Unger's work and the fact that those patients can do every bit as well as those in the urban setting. Novartis did partner with us. We've had 3 trials that we've opened up through this mechanism. Each subsite that opens, they still send a monitor out. We're still trying to develop a system in which most of the monitoring can be done online so that they don't physically have to make visits to these sites, and then try to subcontract for some of the site visits that have to be made. Interestingly, through this process, as we were working it all out, there were several consents involved. First, there's a consent of the patient just to be seen by telemedicine. Then there's a consent for the Novartis trial. So we're over the telemedicine system, we're walking through the consent for the trial itself. And then there's a third consent for the patient to agree to have their care oversight done by an oncologist at a distant site. So it's from an IRB perspective, it has been challenging, but again, we've been able to work out and hammer out the details such that I believe we have a model in place that will enable us to continue to provide trials like these in the rural sector, and we have studies that are ongoing right now. Very quickly, we use the technology for cancer support groups. This isn't all directed to the providers at our sites, but also groups that meet over the system. Again, we talked about a psychologist that provides care over the system like this. Community education events that are geared for cancer patients and their caregivers, geared for survivors and co-survivors. Very quickly, I would tell you that we do have data for telemedicine acceptance. I'm a Kansan, and I'm proud of being a Kansan, and I would tell you that Kansans adapt quickly, and all the data that we have generated with respect to acceptance of the technology and receiving care this way has been positive. If given a choice, I think the patient would rather see the doctor in person. Given a choice, the patient would probably want to see the advanced practice practitioner in person. Having said that, if it means saving a 2, 3, 4 hour drive, the technology works just fine. Some of the challenges that we have, to be quite frank with you, I don't want to belabor it because I think they're all things that we can overcome. And the challenges that we have really have more to do with practice care delivery than the technology and the patients we're trying to serve, right? So it's really a tremendous amount of time up front in identifying how the practice is going to work, what the patient flow is going to be like, how data are going to be collected, how records are going to be kept. There's that upfront time, and that's a challenge. But once things are in place, it's really not so different than clinics in which we see patients in person. This is my final thoughts. To be really honest with you, it can be summed up in it works, and patients adapt, and it's a tremendous way to provide care to a patient pool that when you have cancer, you don't feel well. And then when you couple that with a 3 hour drive one way in to meet your practitioner and then 3 hours back after treatment, it's an incredible burden, both emotionally, physically, but also financially, as we heard from Lisa earlier. And with that, I'll hand it back over to Jill.
Great. Thank you very much. Thank you very much to all 3 of our fantastic panelists. We really appreciate that you took time today to speak to us about really important concepts in cancer care and cancer research. I believe that we had a couple questions and some comments, so I'm going to turn over to Dr. Welch, who I think was monitoring those.
Well, and thank those of you who've already chimed in with some questions and comments. I'll just read a couple of the comments and ask if any one of the panelists might want to respond. One was discussing the financial toxicity issues, and there was gratefulness for having insurance, and believe that the care was better because of the insurance. Lisa, in particular, since you were talking about financial toxicities, do you want to comment on those with and without insurance and the quality of the care between those two?
Can you hear me?
Yes.
Yeah, from the patients that we've talked with, as far as receiving quality of care, we did talk with some patients who felt that because they didn't have insurance, that reflected poorly on them. Their treatment within the system was not as nice as what they would expect if they had insurance. But as far as it being known that they get a less quality of care, I'm not familiar with
Danny, can I make a quick comment too?
Absolutely.
So I'm a medical oncologist, and I'm also a cancer survivor. I had a kidney cancer removed now 9 years ago. So because of a great surgeon and the care that I got, I'm most likely cured. 9 years ago, my out-of-pocket for the nephrectomy was $47, and I had a hospital bill that was $122,000, I think. Last April, I had an NSTEMI, and so I was in the hospital for 6 days. Everything turned out great. I was fine, got discharged, off work for 4 weeks, and my out-of-pocket was $4,700. So the bill for the hospitalization was half of what it was 10 years ago, but my out-of-pocket was now $4,700. I'm very well insured. I have a great policy with the state of Kansas. My monthly premiums, I pay $1,200 myself for my monthly premiums, and it was still $4,700. And part of the challenge is, even if you're well insured, now with the issues of co-insurance, the expenses can be amazing. And patients that have done such a good job and worked hard and they're insured are still, the financial toxicity issues are still huge.
I agree. And actually yesterday I had several suspicious spots on my face dealt with, and it's the second month in a row, and I was absolutely amazed at the with great insurance for a prevention, it was still several $100s out of pocket. So there are a number of issues. Another comment that was made, and Dr. Unger responded, but I think it was private, so I want to make sure that others, he might want to elaborate. But it's the comment that while there may be a good technology for the oncologist to communicate, as Dr. Doolittle was talking about, some patients in rural areas may have more difficulty with ancillary support, the social work, counseling, and so on. And Dr. Unger did make a response, and I think if you don't mind elaborating a little bit on that, I think others would like to hear it. We have you still muted, I think. There you go.
Hi, thank you. There were two questions. One was about oncologists, ancillary support. So no social workers, no financial counseling. And this is Kelly Shanahan, and she suggested that telehealth services would be an ideal area for this. In our research, we also discussed the issue of telehealth and telemedicine, and I certainly agree that technology can be our friend here because, by tying patients from rural areas directly to large oncology centers, either directly or through their local provider, I was not aware that we were going to have such an excellent presentation by Dr. Doolittle about this very topic. So, but I did want to add, just as an addendum, that and maybe turn it over to him to talk about as well. But 2 points. One, Dr. Doolittle talked about the disincentives that are built into the system based just on copays and coinsurance costs. These are, I think this is a largely underappreciated issue. Even if you have insurance, copays and coinsurance can be very prohibitive for patients. Increasingly, of course, as you go down the income scale as well, especially, and it can also impact their participation in clinical trials, which have their own copays and coinsurance, even if you have good coverage. So that can be a disincentive for people to participate in trials. I want to commend Dr. Doolittle for his efforts on telemedicine models for clinical trial participation, which I think he seems to be in the vanguard on, and I just wanted to quickly ask if he had published on that yet, because I would love to see it in the literature so I could refer to it myself. Maybe I'll turn it over to him.
Thank you. Yeah, we submitted an abstract to ASCO last year, and we have a manuscript in preparation. What we don't have is large numbers yet, and these studies are still ongoing, and we're going to need more of a volume. It is a challenge to do this because the sites that we partner with may have 2 medical oncologists, and they have a patient base that is managed by 2 medical oncologists. So when you open up a trial, at any given time during the window that trial is open, the number of patients that are actually candidates for it are relatively low. And so if you judge the success of clinical trials access based on numbers alone, the numbers don't look so great, right? I mean, we've got 1 patient. As a matter of fact, I know this sounds like it's a setup here, but as soon as we finish here, I've got a patient in the rural sector that's on a Novartis trial that I'm going to connect with for her monthly visit. That's 1 patient at that site. So you'd look at that and go, hey, 1 patient. Well, from my perspective as a medical oncologist that feels like rural patients should have access to the same things I can give them here in Kansas City, that's a success. If you look at it even from a Novartis perspective, I think they consider it a success because they're trying to extend their reach. They want to know that when they open up a trial, if we can nail down all of the challenges that we have with this and get all the kinks worked out of this, that just opens up a large patient base for them to have access to for trials in the future. And now more than ever, we're really challenged because these trials have such very specific eligibility criteria they could be based on 1 particular molecular change, and in a low incidence molecular change, we're going to have to be able to have access to these trials nationally to accrue to them. So bottom line, Dr. Unger, yes, we have an abstract out there. We have a manuscript in publication, or it's actually being written for publication that outlines all the different steps it took us to just get this trial open. And I'm happy to share that with you.
Great, yeah. I mean, I envision, in the same way that hardware costs have come down so much that you discussed at the beginning, all the startup efforts that you've put in could, in 10 years, maybe that seems like the hardest part. I imagine that's true.
Yeah.
So very quickly, if you'll allow me to editorialize for just a second to amplify. Since this is primarily targeted to metastatic patients, many go from clinical trial to another clinical trial and so on. So the efforts being made for telemedicine and outreach to people who don't have easy access regardless are absolutely critical for the metastatic patient. And all of the issues that the 3 of you have presented this morning have been ways in which things are improving, but they still have a long way to go. And I'm seeing comments like that on various parts of the screen. And hopefully the folks who are typing in appreciate that I'm trying to just summarize many of them at once, but it's really critical. One last quick question, since we've neared the end of our time. Do you think social media has changed care expectations with rural patients compared to their urban counterparts? Great question. I'm going to leave it to the experts.
Well, I think it has. Just briefly, I think it has changed it, and appropriately so, because it's broken down barriers in terms of distance. It hasn't quite done it in terms of actually physically getting from one place to another, but certainly information-wise, it has.
And I would add that it's not even. I don't know that I would narrow it down to social media itself, except to say smartphones, and the fact that, you know, I don't care where you are in the state of Kansas. I don't care how remote you know your home, where you live. They have iPhones, and they have service, and they have access to the world's literature right in the palm of their hand. And so patients, even, you know, from the rural sector, come in or have questions about the most recent study that was published out of Basel, Switzerland. You know, and you're just like, it's so amazing. It's like the practitioner doesn't deliver information anymore. The practitioner helps the patient interpret it and find out what's best for them. So. And
real quickly, some people on the phone or on this call may be interested to know that out of the Broad Institute, there is a metastatic breast cancer project that's actually trying to connect, I believe already it's over 1,000 women with metastatic breast cancer. They're starting a similar operation for prostate cancer, so that people have access to their information. They're actually sharing genetic information, so it's more freely accessible, and all of that was administered through a social media, Facebook, Twitter, Instagram type of account. So those are things that are ongoing. So it's a great question, and we're people in the field, both the clinicians and researchers, are trying to take advantage of the technology and provide access to everybody. So with that, Jill, I think you probably had a couple of final comments.
No, I know we're at 12 noon, and again, I want to thank our panelists for sharing your expertise and your passion about cancer care and cancer research. We are hosting 2 additional webinars, one in February and one in March. The February webinar will be focused on metastatic prostate cancer, and the March is about challenges in designing clinical trials and research for patients with metastatic cancer that I think we've touched on a little bit today, and we'll continue that conversation then. So thank you again to everyone who joined the webinar today. It has been recorded, and we'll send out the link to the recording this week.
Thank you.
Thank you. Bye-bye.
Bye.